Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hello and good evening. My name is Gordana Milovic and I'm the chair for the Association for Child and Adolescent Mental Health. I'm delighted to welcome you to the India ACAM webinar entitled Nuts and Bolts of Pediatric Psychopharmacology and Management of Psychosis in Children. Now, this event is part of ACAM's India free webinar series. And we hope through our lectures and talks to stimulate interest amongst practitioners and enhance learning of child and adolescent mental health. This webinar, I hope, will stimulate interest amongst practitioners and enhance learning. It will provide practical insights in the area of pediatric psychopharmacology. So the focus is on practice, but practice which is underpinned by research and evidence. So I'm delighted that you could all join us. I am joining you from a very rainy Brighton in England. Windy and rainy, I should say, but I shall stay with you for the duration of these talks. And I will now like to hand over to my colleagues, Dr. Kshitij Srivastava, who will be chairing the proceedings, and Dr. John Vijay Sagar, who is co-chairing. And of course, Dr. Sumitra Datta is here to field your questions. So please put your questions and chats in the chat line and the question and answer sections. So I hope you have an enjoyable evening. Bye for now.
Thanks, Gordana, for that very useful introduction to these couple of talks. We have a couple of very exciting talks lined up. And we have two excellent speakers, Dr. Isha Sharma and Dr. Sumitra Shankar Datta. As you're probably already aware, the talks are about, the first one is about the basic principles of psychopharmacology in children and adolescents, which is a very important topic considering that, I mean, most of us, most psychiatrists in India are used to giving medicines to adult psychiatric patients. Psychopharmacology, while similar, it has some very important differences when it comes to the pediatric population. So we'll talk about a lot of interesting things which we have to consider in this population, like different pharmacodynamics, different pharmacokinetics, giving rise to different drug effects, both beneficial and side effects, different dose calculations, different expectations, and probably most importantly, the paucity of research in this area. So Dr. Isha Sharma will do the first talk. I would request Dr. John to introduce Isha.
Thank you, Kshitij. Dr. Isha Sharma, our first speaker for today, works as an assistant professor of child and adolescent psychiatry. In fact, she is my faculty colleague at NIMHANS. She completed her master's degree in psychiatry at NIMHANS, followed by postdoctoral fellowship in obsessive compulsive disorders at NIMHANS. And recently she completed her PhD at NIMHANS. Her areas of interest include psychopathology, psychotherapeutic process, psychopharmacology, biological psychiatry, outcome assessments, health systems, and psychiatric epidemiology. So now I hand over the session to Dr. Isha to start her session. Thank you.
Thank you, sir. It is indeed, it's always difficult to talk to professionals, to talk to a group, that's already in a particular field, because you always wonder what is it that I can add and what is it that I can bring to the table. But I think the topic given to me has been quite strategically given as basic principles of psychopharmacology. And I hope to just do that to help us all revise some basic things that we probably read and practice day in and day out. But I'm just going to try and bring all of that together in a presentation to recap it for all of us and to also see where the field is headed, where we've come actually, over the last 20 to 30 years and where we're headed in terms of assisting children with these molecules that we day in and day out practice. I'm delighted to be doing this for the ACAMH, and it's I thank Dr. Soumitra Datta, Dr. John, Dr. Kshitij, and everybody else involved for giving me this opportunity. So let me start by sharing the presentation with you. Thank you. So, right, so basic principles of pediatric psychopharmacology. This is a brief outline. I'm just going to do a brief introduction, then get into the kinetic, dynamic, and development related issues that we keep in mind while using these molecules with young people. An overview of the evidence base. It's really going to be just an overview because we cannot get into any more details in the format of today's presentation. And finally, a little bit of reflection on what the future is looking like for pediatric psychopharmacology. So as we all know, way back in the 30s and 40s was when we accidentally saw, a group of researchers found that children who were dysregulated, who had emotional behavioral symptoms, a drug called benzedrine was actually helping them to calm themselves down, to become more manageable in terms of behavioral control. These medications were also used in populations of children who were coming into conflict with the law. And there again, they were finding, so, these very early serendipitous discoveries kind of pointed us to the fact that, we're looking at some things, at some chemicals, some molecules for adults with behavioral problems. So may the same also be true for children, which we didn't really know much about at that stage. But then, of course, over the years, we have realized that, and, I'm sure all child mental health professionals in the audience and in the panel today will agree with me when I say that at best, everything that we do as child mental health professionals, we day in and day out in our practice realize that the focus on the child's psychosocial environment is paramount. And pharmacotherapy most of the time becomes adjunctive to psychosocial interventions, right? So we're all familiar with Bonfim-Renner's socio-epidemiological model, where the child is at the center of multiple layers of the environment. And, most of the children that we come across in our clinics, we realize that, it's these layers and it's the psychosocial environment, it's, relationships with the parents and with peers and in the school. So there's a whole lot of thing going on in the child's environment. And that's really where we end up working for the majority of the time. And we use psychopharmacological agents to assist our work in that area. But then, of course, we also know that there are, core psychiatric disorders in young children, severe mental illnesses like schizophrenia and bipolar, also depression, anxiety disorders, OCD. So children actually experience the entire spectrum of psychiatric problems. And for them, of course, disorder-specific medication, etc., have to be used. And, we do have some evidence now to say that they are equally effective for children as for adults. But for the larger part of the practice, pharmacotherapy is adjunctive. And, that's a key message that we need to carry for most children that we come across in our practice. I'd also like to, at the introduction state that there is a lot of variation, across the world in terms of how pediatric psychopharmacology is practiced. Sitting at NIMHANS, we get so many referrals from different parts of the country, and we often wonder that, how these molecules are used in these different parts, because sometimes we feel that it's very different, so whether it is treatment of ADHD in very young children or, treatment of depression in adolescents, treatment of OCD, using clomipramine and other drugs. So very often it looks like that it's not just the evidence base that is guiding your choice or use of psychopharmacological agents in children, but there is a whole lot of other things, so what is the context that the child is coming to you with? What are the practice patterns in and around your area? What are the regulatory practices? What is the regulation set in your state and the country, etc.? What are the public attitudes? And public attitudes One, of course, that operate at the more general level in terms of how India as a culture feels about diagnosing psychiatric problems and treating psychiatric problems in children. And public attitudes can also be more local, in terms of what this particular child in this particular family is experiencing and how accepting or non-accepting the parents are of diagnoses and treatment. So ultimately, practice is governed not just by the evidence that we're able to generate, but by a whole lot of other factors that as clinicians, we need to pay attention to when the child is sitting in front of us. But having said that, over the years, there has been a shift in approach, so there was some serendipity in the 30s, 40s, and then everybody forgot about it. And then again, some interest came up in the 1980s, 90s, and then slowly over time, we have begun to understand that core psychiatric problems exist in children. They need to be identified, they need to be treated because they are dysfunctional and they will have an impact on the long-term development and outcome for a given child. So from a least restrictive and lowest effective dose approach to shifting to a most effective treatment approach is what we've been looking at over the years, and that's where we're gathering the evidence for pediatric psychopharmacology. So looking at the developmental, kinetic, and dynamic parameters that we need to be aware of, this is something that I use with the student classes I do for pediatric psychopharmacology in the department, where if you just think of psychiatric problems that are arising in the brain, and when we look at adults, we focus on a very important part which is called the pre-morbid personality. And we try to identify how was this person usually like, what was this person's behavior like, how would they generally deal with the situations, cope with stress, and how has that changed? And where was the onset and how did it change and what do I need to treat? So there is a very clearly defined pre-morbid self that you have as a comparator. But in children and adolescents, the pre-morbid self is a moving target, because children and adolescents are growing and developing. They're imbibing so many things from the world, their emotion regulation, social capacities, everything is changing. So it is important to kind of understand this and keep a developmental approach in all the assessments and interventions that we do for children, lest we actually miss what is it that we're trying to achieve. And quite interestingly, even if we look at the median age of onset of different psychiatric disorders across the developmental span, we realize that there are the disorders that onset during the childhood period, or that are most commonly diagnosed during childhood and adolescence, which is ADHD, anxiety disorders, sometimes severe mental illnesses, substance abuse. So while all of these disorders are peaking onset, in the childhood and adolescence period, in parallel, critical brain areas are actually undergoing maturation. So how much of the maturation in these brain areas actually impacts the onset and development of these disorders, and how much does maturation actually help in the remission from these disorders? We know that children who get diagnosed with ADHD, even illnesses like obsessive compulsive disorder, we know that a substantial proportion of them do not retain the diagnosis and follow-up, right? So the onset of a disorder as well as the course and remission from a disorder are intertwined perhaps with the way the brain is developing over time, and one needs to be cognizant of that in every follow-up. What does this mean clinically? This means that every time you assess a child, every time you intervene for a child, you have to keep in mind what is the current developmental stage. Am I seeing something that should not be expected at this stage, or that should have matured by this stage? So that is the developmental comparator for us. So generally, a child in this particular age, what must his or her developmental capacities be like, and what am I seeing that's different from that? And that then helps me understand what I need to intervene for. So the developmental background is important to appreciate in children and adolescents, even when using psychopharmacology. Similarly, just like we understand how development is shaping the presentations. From the pharmacological perspective, it is a good idea to have a know-how of what the pharmacokinetic and dynamic principles operating at this age and stage are. So, we look at pharmacokinetic parameters in terms of factors that affect absorption, distribution of the drug, metabolism of the drug, and excretion of the drug. Now, for the most part, at least all the parameters affecting absorption of the drug are actually matured well within early infancy. So this is not really something that we need to bother about when we are prescribing medication to children. I mean, usually we don't use medication before they are late toddlers or preschoolers. So by that age, this part of the kinetic parameters is fine. In terms of distribution and metabolism, as well as in terms of excretion, there are important differences that we need to keep in mind as we're using drugs. For example, preschoolers have a larger volume of distribution. We know that children have a larger surface area. And in fact, a lot of drug dose estimations are done based on the surface area rather than, the weight-based calculations that we do. Similarly, preschoolers and young children may have an overall lower protein content. They may have higher blood flow, which would affect metabolic handling of the drug in the body. And there may also be higher renal clearance still preschool. So we're looking at, the importance of these differences till, say, the age of about, as this chart tells you, sorry about that, till this chart tells you about the age of, preschoolers. So, by the time they are 4 or 5 is when all of this is actually undergoing maturation. So if you're using molecules before the age of 4 or 5, it is important to keep these critical aspects in mind while prescribing. Now, what does this mean? Does it really mean that we have to not use these drugs? Does it mean that we use them in very different doses? So I'll be talking about the typical doses, etc., that we use. But overall, the thing to keep in mind is that whether you're dealing with very young children or with slightly older children as well, because the brain is developing, how a drug is going to work may not be exactly like adults. How the body is going to handle this drug pharmacokinetically, may not be exactly like adults. So all of this basically means that using pharmacological agents in children requires a degree of caution. You start with doses that are much lower, than what we start with in adults. You take a very slow up titration. And then you actually, review at every follow-up and check at every follow-up how the child is tolerating the drugs, how are the side effects developing, is there any meaningful efficacy that I'm able to see in this child? So overall, this is what it means. It doesn't at all mean that we cannot use these drugs in children. We can use, but it has to be done very, very cautiously because the kinetics and dynamics are at best unpredictable in children, more so the younger the child. In terms of pharmacodynamics truly is something I guess that the entire field is struggling with, even in adult subjects. So that they've conducted genome-wide association studies, combinatorial gene guidance for adult subjects. They have done gene medication association studies even in children. And if you will go through all of these studies in detail, what this table basically says is that there are no clear winners, because we don't really know whether a particular gene polymorphism or a particular type of receptor profile helps us decide one molecule over the other. So in terms of pharmacodynamics, we don't really have gene-specific or gene-related insights into which drug or which molecule to choose for a particular patient. I've put in this slide, specifically because recently, and Dr. John could add to this perhaps later, we have had a lot of families actually coming in with pharmacogenomic analyses. And these are like these very, very bulky reports where multiple genes and, they use different kinds of microarrays and, different genetic association, etc. So a lot of gene-based evaluations done to give some kind of a profile, some kind of a report about which molecule might or might not work. But looking at the current evidence regarding gene-related specifications for drug use. The only recommendations that are meaningful at this stage is that widespread testing is not recommended. And many international associations have actually sounded these out in their very decent guidelines that you cannot and you should not test pharmacogenomics for patients who come to you routinely in your clinic. There may be some role in treatment non-responders, right? So if somebody is failing trial after trial of medication and you're not able to hit a molecule that is actually going to help them, there may be some role there, but then again, it's not something that gives you a clear answer. That there may be a lot of interpretation analysis that may have to be done even there. Now, because we know that there are probably genetic effects, there are these kinetic and dynamic variations in children, adolescents, adults, and everyone. So rather than doing testing, what we basically need to do is start low, go slow, and monitor. Right, and that's that probably has a better evidence base than doing these very expensive tests that don't really give you clear answers. Also, drug-drug interactions become important, especially if you look at these molecules. And I suppose all of you are familiar with the drug interactions that become significant for drugs like fluvoxamine, atomoxetine, carbamazepine, phenytoin. So these are common drugs that we all use, that we know we have to be careful about. We have to check every time we're adding a new molecule to see how it may interact and change the drug concentrations in the body, basically because it's going to add to side effects and may or may not impact the efficacy of the drug. So yes, we have to keep kinetics and dynamics in mind, but these are the recommendations we go ahead with. Right. So with that background on the moving developmental target, the moving premorbid self, to keeping in mind the kinetic and dynamic parameters, let me now briefly take you over what kind of evidence we have for pediatric psychopharmacology. I like talking about the ADHD study simply because these studies actually kind of started making us believe in pediatric psychopharmacology, because for the first time we were doing randomized controlled trials, and both the MTS study as well as the preschool ADHD treatment study were both so wonderfully conducted in terms of the sample size, in terms of the arms of treatment that they had, the kind of assessments they did, because they focused not just on the ADHD symptom reduction, but they looked at all kinds of externalizing, internalizing outcomes, academic performance, parent-child relationship, social skills. So they actually did a very wide outcome assessment, which was very, trying to probably mirror what a real clinic setting looks like. Plus, for example, in the MTS study, in a sample size of more than 500 kids, in a very typical age range where you diagnose and treat ADHD routinely in the clinic, they had treatment arms with intensive medication management, intensive behavioral treatment, a combination of medication and behavioral treatment, and routine community care. So it's been so well thought out of that. Let's just compare everything that's happening out there and see what works. Of course, this was NIMH funded, multi-centric, etc. What this study has been able to tell us, and something that we are keeping with us every single day that we sit in the clinic, is that for children with ADHD, medication or a combination treatment, that is combination of behavioral and medication interventions, is more efficacious than doing only behavioral treatment or basically doing non-evidence-based treatment. The combination is especially more effective if there are comorbid conditions like anxiety, if a child has academic issues, if there is interpersonal stress. When we think about it, how many children come to you that have only ADHD? I mean, that's clearly the minority. Most children with ADHD who present for treatment, do end up having some comorbidity, either a comorbid diagnosis or academic and parental stress that they find hard to cope with. And in all such conditions, a combination is the gold standard. The dose of medication is lower with a combination treatment, understandably. But of course, there is a high individual variation. And, to me, these findings of the MTA actually define pediatric psychopharmacology. So you have to do combination, you have to individualize your intervention. You can keep your medication dose low if you're doing enough psychosocial input. This in a way talks for all kinds of child mental health problems that we address in the clinic. But some of the other important insights that we get from the study and the PATS is that were there side effects? Yes, there were side effects, but were they severe enough to prompt discontinuation of medicines? No, they were not. So only about 4% kids actually went off medication in the MTA trial because of different kind of side effects. And there were important moderators and mediators of treatment that they were able to identify. So if a child has anxiety, if there is parental depression, if there is high illness severity, if there is low intellectual ability, then these are factors that will actually contribute to poorer outcomes at follow-up. Whereas there can be mediators of improvement. So if the treatment is well accepted, well adhered to, and if there is an improvement in parenting, then all of this actually supports a better outcome, right? So, this study alone gives us so many messages about, what we need to focus on when doing pediatric psychopharmacology practice in the clinic. So looking at, so once they had evidence for older children with ADHD, of course, the interest shifted to preschool children with ADHD to see whether there is any, role and whether there's even any need of treating such young children. So this was again an NIMH study, multicentric in the 2000s. They took children who met criteria for ADHD. So these were preschoolers, but they met criteria for ADHD as per the DSM-4. This was an RCT, and again, it looked at both efficacy outcomes as well as effectiveness. So which means that, again, they had, multiple outcome assessments. They asked the parents, they also asked, a daycare or an early education center that the child was attending. So again, they looked at multiple outcomes, which were parent and teacher rated. So even in preschoolers, they were able to demonstrate a reduction in ADHD symptoms. And, they were also able to show that using very low doses doesn't really help, so you can't just give some bit of MPH and feel that, okay, maybe because a child is young, they will benefit with this alone. You have to give, decent amount of doses according to the age and weight of the child. The mean optimal daily dose was actually more than 10 milligrams per day, and this is something that, you may have experienced using with older children as well. So even with the younger ones, the doses were decent enough, as used in clinical practice otherwise. Remission was seen, in significantly higher number of children on MPH as compared to children on placebo, right? So it's not 100% remission, but at least there is a substantial difference compared to placebo. The worrying thing was, of course, and this again to reiterate what we were talking about in terms of pharmacokinetics and pharmacodynamics, the younger the child, the more likely that there will be drug handling challenges in the body, and so the discontinuation rates were higher, side effects were spontaneously reported. And in follow-up, what happened is that 80% children retained the diagnosis. Right. And this, in fact, is an important takeaway from this particular study, that say a 4-year-old or a 5-year-old child comes to you and you feel that the child has, symptoms of ADHD. Should you diagnose and should you intervene? You probably should, because there is a high likelihood that, the child may actually continue to have those symptoms as they grow up, especially if a child has comorbid disruptive behavior disorders like conduct or oppositional defiance. So if they have more externalizing, more disruptive presentations along with the ADHD symptoms, then the higher likelihood that the diagnosis will persist and they require treatment. And there were similarly other factors that contributed to different kinds of outcomes and follow-up, but I'm not going to get into that in the interest of sticking to psychopharmacology. But enough to say that MPH can be used in young children. it does seem to have an effect, but yes, we have to monitor and watch for side effects that may be much more common at this age. So overall, in terms of treatment of ADHD, which is, of course, the most common, one of the most common presentations in child mental health clinics, we have 3 drugs that we're looking at in the Indian setting. All of them, directly or indirectly, are working on neurotransmission systems in the brain. Methylphenidate works on both dopamine and norepinephrine, whereas atomoxetine is more specific to norepinephrine. Clonidine is, of course, an alpha-2-adrenergic agonist. So by being an agonist at this particular receptor, it actually, again, increases norepinephrinergic transmission in the brain. The dosing strategies in terms of methylphenidate being used at around 0.5 milligram per kg, atomoxetine at around 1 milligram per kg, and clonidine, of course, is we don't really go so much exactly by weight, but we start really low at about 0.05 milligram per day and increase it very, very slowly at about weekly intervals to finally go up to about 100 or 200 micrograms per day. For older kids, if we are actually using clonidine, then even going up to 300 micrograms per day can be practiced. Other than atomoxetine, both of these drugs have to be given in divided doses, right? Because MPH especially has a very short half-life, as does clonidine. In fact, clonidine, if you will remember from your pharmacology during MBBS, is actually one of the hit-and-run drugs. It gets in, does stuff quickly and gets out of the body quickly. So it needs multiple peaks throughout the day to actually maintain effective serum concentrations. The effect of methylphenidate can be seen within hours, right? And parents will actually tell you this, that from the very few, first few days, I could actually see that my child was calmer, they were able to sit for longer, work for longer, etc. Atomoxetine takes time. Clonidine can have, some immediate benefits because clonidine, also is a very sedative drug. So it can actually help calm the child down by its sedative properties quickly, but then of course, greater benefits in terms of overall symptom score reductions may take longer. There can be adverse effects with all of these 3 molecules. There are some adverse effects that overlap between methylphenidate and atomoxetine. The rebound withdrawal effects, because of their short half-lives and quick mechanisms of action, are more with methylphenidate and atomoxetine. The important thing to keep in mind with atomoxetine is a black box warning for hepatitis, aggression, and suicidality. And routinely, when we're prescribing any of these medication for children, it is a good idea, with both of these molecules to get, some basic lab work done before you begin them, especially a liver function test. With clonidine, of course, monitoring blood pressure and ruling out any pre-existing cardiac problems is important. Now, the important thing to in terms of choosing which molecule do I go ahead with in a particular child who presents with ADHD. So clearly, methylphenidate is the first choice. It is the most efficacious molecule that there is to treat ADHD that is available in India. It works on both aspects of the impulsivity, the inattention, so it helps in all kinds of symptoms of ADHD. So it clearly is the first choice. But the trouble with methylphenidate sometimes can be that it can be a more activating drug. It can have some of these very problematic side effects. It can sometimes contribute to seizures and other complications. So if there are contraindications to using this, then atomoxetine is something that we do consider. But having said that, sometimes children who present with so a child with ADHD, but also with a lot of depressive features, a lot of negative affect, difficulties in regulating emotions. So that may be a group where probably trying out atomoxetine earlier may be something that can be looked at. And as you may recall, atomoxetine was originally actually tried as an antidepressant. It was accidentally found to help with attention-related symptoms, and that's how it got shifted to this part of pharmacology. So there may be some merit in using this with this cluster of symptoms. Clonidine is something that works well with tics. So children who have ADHD with comorbid tics, that's a space where clonidine might be more efficacious. But, so these are all clinical decisions that, will need to be taken in individual children. The major considerations would also include how feasible it is to follow up, because MPH is a regulated drug, so it is something that can only be given on prescription. So they will need regular follow-ups to refill, etc. How you can monitor side effects, whether there are comorbidities, say a child has a mood disorder or, tics, and you've noticed that the tics are worsening, then it may not be a good idea to use methylphenidate. Clonidine may be the clear winner there. So comorbidity can sometimes decide which molecule you choose over the other. Also, it is important to keep objective feedback as you're using these drugs, because many a times, given that these conditions can be highly comorbid and there may be parenting and other stress playing out in the background, it may not be easy for parents to actually talk about what has improved and what hasn't. So it's important to keep an objective rating as you move ahead with treating these children. There has been a resurgence of interest in growth reduction with the use of stimulants, and there are actually systematic studies being done which have demonstrated significant reductions in weight and height within 11 months of therapy. And how they measure this is that they don't look at absolute weight and height, but they look at weight velocity and height velocity. And if you see that the velocity of increase in height and weight is significantly changing in a child, then that should raise caution, and basically you increase monitoring. You figure out where the eating problems have been, using medication after meals, and doing other things to basically kind of try to accommodate for the reductions in weight and height that are happening because of the drug. Now, this is something that we basically have to go back and discuss with the child and the family in terms of a risk-benefit analysis. So how much is ADHD actually interfering with this child's life versus, how much are the parents and the child bothered about the weight and height changes? So and of course, if there is significant weight reduction, that is clinically significant and needs attention, then that is something that has to be dealt with. So this is something that we need to keep in mind while using these molecules. I'm going to quickly look at the role of SSRIs and antipsychotics in young children. So this is an interesting table, because what I was mentioning earlier, that very often you will find yourself at the ultimate target dose ranges, which are very similar to what we use in adults. So we use 40 milligrams of fluoxetine, 150 sertraline, etc. in adults. So the final dose may actually be comparable, but look at the starting dose. The starting dose is almost 1/4 of what you would start in adults, or even lesser than 1/4 of what you would start in adults. And this is the difference in pediatric psychopharmacology in using SSRIs for different conditions. And that they have been used for OCD, they have been used for depression, for anxiety disorders. So they have actually been tried and tested for the entire spectrum of conditions, just like in adults. But this is where the difference lies, that you have to start really slow and go really slow to ultimately reach similar doses as you do in adults. A frequent issue that arises is how long to continue? Is the depression always going to be there? Can my child go off treatment? And at best, these are all clinical judgments that you have to make in individual discussions with the child and the family. But we do know that relapse rates can be higher, much higher compared to adults, and there is a likelihood of persistence of disorders. A substantial proportion of children will actually come out of the disorder, but there will still be a big chunk that persists. We don't have clear markers for who's going to persist. So, the decision to discontinue has to be individualized. Some adverse effects of concern with SSRIs include, of course, the GI related and headaches and fatigue that we sometimes see in adults as well. But in children, what becomes important is the behavioral activation related side effects, which are more common in children, especially early in treatment, every time you increase the dose or when there are drug interactions. and it can present with restlessness, insomnia, impulsivity, disinhibition. And, it would become important to distinguish this from hypomania, mania, and then, do what is needed in order to reduce the activation by either lowering the dose or even stopping the drug for a while, and then seeing, how the symptoms proceed. There was, a lot of concern about increasing suicidality with the use of SSRIs. And, there was even a commissioned systematic review to look at data pre and post the use of SSRIs in children. Currently, the understanding that we work with is when a child needs treatment with SSRI, he or she must be given treatment with SSRI, right? So there is no doubt about that. So if there is clinical depression, OCD, anxiety, any, clinical presentation that would benefit with SSRIs, we must use it. But we must use it with adequate monitoring, just like we do for the dose and other side effects. There is a lot of concern about how we assess suicidality. So is suicidality a suicide attempt? Is it suicidal ideas? Is it death wishes? Is it suicidal plans? So suicidality itself can be a spectrum of conditions, but overall, if a child needs it, we must give, if at all these side effects emerge, if at all suicidal ideation emerge. The role of other antidepressants is not as well studied, but of course, in the clinic, we do end up using venlafaxine, especially for older adolescents at times who present with depression or, other anxiety, and, sometimes even for treatment-resistant OCD, but, much lesser as compared to SSRIs. The other medication, there is not a clear supportive evidence in terms of recommending them as first line or immediate second line, but they, on a case-to-case basis, we can look at trying them. There would be greater comfort in using any of these molecules the older a child is, right? Because the younger the child, with the paucity of evidence that we currently have, the risks may be higher. Multiple antipsychotics have actually been tried in children for a wide spectrum of conditions, schizophrenia, bipolar disorder. But the more interesting parts of using antipsychotics in children is, for example, for disruptive behavior, for tics, as augmentation strategies, either for OCD or depression, so using these molecules for augmentation, for aggression and hyperactivity related to neurodevelopmental conditions. So antipsychotics, unlike for adults where, we end up using them for very clear-cut severe mental illnesses, for young children, aggression can be a very frequent target for, treating with antipsychotics. And there has been established efficacy in using these molecules here. Of course, risperidone tends to be the one with the maximum evidence base and with, substantial literature around it. Aripiprazole has been recently gaining a lot of momentum for very similar conditions like risperidone. Again, the doses, because you're not really giving this for schizophrenia, so you start again at less than 1/4 the dose that you would for psychosis or bipolar. Similarly with aripiprazole, so as low as 2 milligrams per day can be given for these kind of conditions where it's non-syndromal problems that you're trying to target. First generation antipsychotics are not commonly used. Because the second generation are simply more effective and, that they have a larger evidence base. But sometimes molecules like chlorpromazine can actually be very useful for children who have a lot of behavioral dysregulation and a lot of arousal symptoms. Using that at as low as 25 milligram per day can help children settle down in, the behavioral and emotional dysregulation that they experience. The concern with using antipsychotics for children is, of course, largely to do with the metabolic disturbances, because these kids are young. You don't know how long you have to give these molecules. Putting on weight and adding to cardiometabolic risk at this age can actually predict long-term metabolic disturbances in the individual, and that's an area of concern. So close monitoring of the weight, metabolic parameters must be done every time that we use these molecules. There can also be extrapyramidal and prolactin-related side effects, but EPS, especially not in very young children. So very young children don't seem to develop EPS very easily, but with the adolescent age group, EPS can be significantly concerning, and it has to be adequately addressed, with anticholinergics, etc. However, especially for young children, sometimes it is possible to use antipsychotics without adding THP because they're not very prone to extramedullary side effects. So you don't have to by default add THP like we do sometimes for adults. So you can actually wait and watch, and if there is a need, then add this molecule. I've put this in just to direct your attention to this wonderful molecule called lithium. Lithium has been tried and tested just like for adults and pediatric bipolar disorder as well. Of course, the other antipsychotic molecules have been used, but lithium has been used. It is, the first line drug for all kinds of bipolar disorder presentations, even in children. And the interesting thing is that, again, look at the daily dose range, right? So from as low as 300 milligrams per day to as high as 2,400 milligrams per day, right? So, and this again to bring back the kinetic considerations that we were talking about earlier, because we can't really be sure about how they're going to work. The dose may actually be very, very variable, as may be the effective therapeutic level, right? So up to 1.4 milliequivalents per liter sometimes can be tolerated by children. It doesn't mean this is the recommended range, but this seems to be the upper range that studies have documented. So lithium is something that can be used and should be used in children with bipolar disorder because it has the maximum evidence support for treating this condition. I'm just going to quickly look at two indications, so autism and aggression. Very often autism, children with autism will come with different kinds of behavioral problems. Children will come with different kinds of underlying problems, but the primary concern that the parents have is aggression. Now, what do you do, because we don't really have a medicine for autism, right? So till date, there is no drug that directly ameliorates the core symptoms of autism. There is, significant support to saying that you can identify target symptoms of treatment. So if you identify that a child with autism has hyperactivity and impulsivity, treat that. And treat that with what? Treat that with stimulants, treat that with atomoxetine, treat that with low-dose antipsychotics at times, but you can treat target symptoms. You can, give medication support for agitation and temper outbursts. Sometimes if you feel that the temper outbursts are driven by a negative mood state, then using SSRIs or using, sometimes even low-dose antipsychotics can help with, the child to calm down. Medication can be used for aggression, they can be used for repetitive behaviors, they can be used for sleep problems. And, there can be different types of medication that can be tried for all of these. There are wonderful review articles that actually look at the different groups of medications that have been tried for these target symptoms. Why should we use medication for children for these target symptoms is because the use of medication could allow children and adolescents to maximize their benefits from the behavioral and psychoeducational interventions, right? So why we want to use medicines is because we, what I tell parents and children and families is we want to cover all our bases, so if there is something that we can do to support you additionally, why not? And, and even when we're using medication for these target symptoms, it happens in discussion with the family and we say that, look, this seems to be a target problem. Let's see if adding this molecule in addition to all the behavioral and, other interventions that we're doing, let's see if it makes a difference. And, we give a trial period of, let's say over the next 1 month or 6 weeks, we will see whether this medicine makes the difference to a child in any way. And if it does, we continue it. If it doesn't, then we again talk to the parents about, do you want to continue? Do you want to wait for some more time to see if it has an effect, or do you want to, go off the medicine? So it's important to have a clear target and then use medication to support children to handle these different behavioral and emotional concerns. Similarly for aggression. And, so for aggression, any and every medication in psychiatry can actually be used to handle aggression, depending upon what, your analysis tells you. So doing a good ABC analysis, a functional analysis, there was this big talk at one point about hot aggression and cold aggression, so concepts like that can actually help you decide that, a particular child seems to be getting aggressive because there is a lot of negative emotion, there's a lot of anxiety, there is a lot of distress, and that is what is, creating the space for the temper outburst. So giving a child like this SSRIs may actually help, bring down the emotional dysregulation that the child is experiencing. So the choice of medication for aggression is not clear cut. It actually depends on what you understand from doing a very good analysis of the aggression, and then, deciding what medicine to use. Finally, coming to the end of my presentation, a lot of parents will come and ask, but what's going to happen to my child's brain 5 years from now? You're giving this medicine now, but will it permanently change my child? Will it create, will it interfere with their development? Overall, it looks like interventions have a normalizing effect. So interventions create the opportunity for a child to engage better with the environment, and because of that, their learning is overall benefited. Because of that, their ability to capitalize on experiential learning is actually enhanced. A drug like lithium has actually even been seen to normalize certain brain volumes when used in children. Neurocognitive functions are corrected. A child with ADHD who will have neuropsych dysfunction may perform better when they are on MPH or atomoxetine. But what we don't know is that, is there a critical window period for benefit? So if a child comes to you at 13 years and ADHD was never diagnosed, is there still merit in giving MPH? Or have I missed the bus because they're coming so late? What actually mediates the brain changes and the clinical benefits? We don't know. How do trajectories differ in children on long-term medication? So we don't really have clear answers to this, and that's what we tell parents, that we don't know, very specific answers to all of these questions. But this we do know, that if children are better able to engage with the environment, that benefit is certainly outweighing any risks that we understand as of today, that the child may have in the future. There is an interesting concept of neuronal or neurochemical imprinting, which says that long-term effects of drug exposure can be delayed, and they may come to expression once the vulnerable system reaches maturation. So basically to say that they are doing something today that will not show you an adverse effect today. The adverse effect will show when they're 25 years old. But we don't have direct empirical evidence for this, but it is something that is a concept waiting to be examined. So there is an interesting study ongoing. It's called the EPOD study, the effects of psychotropic drugs on the developing brain. And there have been very interesting publications from this study, which is looking at treatment-naive boys and men, what happens to their brains when they take MPH, right? And so some of the things that's come up is that, it seems that cortical thinning in children compared to adults is differently affected when they take medication for a certain amount of time. So yes, there are brain changes happening because of medicines. What these brain changes mean, we still have to learn, but we have, researchers have been able to demonstrate that there are brain changes in volume, in cerebral blood flow, in dopaminergic neurotransmission, as well as in parameters like sleep, right? So we are slowly understanding about what these drugs do long-term to the brain. And hopefully we will learn more as we go along. So what has the several years of psychopharmacology helped us do? We've certainly learned about that there is comparative effectiveness, safety assessments. We know that these drugs are safe and can be used in children, but there are important effects like cardiometabolic side effects to be kept in mind. But real world outcomes, trials with social interventions are there drugs that actually modify the course of the primary targets for psychopathology? Have we been able to use neuroscience-informed psychopharmacology? For the most part, psychopharmacology has been serendipity. So there are still a lot of unneeds going forward. And this is my last slide. So, in pediatric psychopharmacology are that there is a primacy of and a greater advocacy for non-pharmacological. So when a child does not have severe mental illness, for example, the combination treatment is the gold standard. It is important to set and going to do for your child. It's important to tell the parent that. Begin with less, go slow, monitor efficacy and adverse effects. Many a times, there may be polypharmacy, especially if a child has very severe symptoms, and that's not something to feel worried about, but it is something that ends up happening sometimes for children because the symptoms are just so severe. But what we must do is allow time for an adequate trial. Don't be in a hurry to change medication. If you're using antipsychotics, give it at least 6 weeks. If you're using antidepressant, give it 6 weeks. You tell us, yesterday we added sertraline and today the child is better. That's not going to happen. When the drug is likely to show maximum effect is clearer to the parents. Where possible, change only one drug at a time and monitor an outcome in more than one setting, which is, of course, golden practice rules in child psychiatry. With that, I come to the end of my presentation to leave you with the idea that psychopharmacology requires a sense of humor. It seems there is a drug of choice for every age, other than the golden age of 18 to 24. So sometimes the best use of evidence-based medicine is to remember how little evidence we have. So keeping that in mind, keeping ourselves humble will be an aid in clinical practice. Thank you very much.
Thank you, Isha, for a very comprehensive, session. Now I hand over to Dr. Kshitij.
Yes. That was almost a crash course on pediatric psychopharmacology. Very, very comprehensive. We hardly missed anything. And I'm afraid you also did some of Sumitro's talk as well, psychosis management. I think let's take questions after we do both the talks. Let's, from a very, very comprehensive this background, let's move on to the next talk by Sumitro Shankadatta, a very close friend of mine. So this is on the management of psychosis in the pediatric population. Dr. Sumitro is a consultant child psychiatrist, currently working in pediatric liaison psychiatry at Tata Medical Center, Kolkata. His research interests include psycho-oncology, decision-making, attachment, and social aspects of medicine. Sumitro holds an honorary research appointment with the Institute of Clinical Trials and Methodology of the University College London. He trained in psychiatry at CMC Vellore and also in the United Kingdom, where I first met him at the Maudsley Hospital. He was a consultant there at Maudsley and King's College Hospital prior to him relocating to India. He has been a lead reviewer for Cochrane collaboration, and his recent Cochrane review on psychological interventions for adolescents with psychosis was a featured review of the Cochrane collaboration. I'm sure he's going to talk about that too in his presentation. So with that, over to you, Sumitro.
Thank you so much for introducing me and the kind words. And it was really a good, vibrant introduction of Isha, which would help us to come to the next part. And my talk would be primarily focused on psychosis. And I don't have any conflict of interest to share. Now, coming to psychosis in children and adolescents, I think we would talk a bit about what are the presentations of psychosis in children and adolescents, what are the differential diagnoses, how you might make mistakes in making the diagnosis, and what our reviews over the years have, what we have found in the research we have done, the meta-analysis and the Cochrane reviews in this area. And we will try to tie it together. What do you do when you have a child with psychosis or an adolescent with psychosis in front of you? So over the next 20 minutes or so, we would go through this. Now, the presentation of psychosis in youth, the diagnostic criteria is the same as in adults. They have positive symptoms, negative symptoms, disorganized thought. However, for a very young child, sometimes formal thought disorder may be confused with language disorders. If there is, or the other way around, if there is a language disorder, you might misdiagnose that as a formal thought disorder. There are other misdiagnoses as well, which we'll talk about in a minute. We have to understand that cognitive decline typically stabilizes after some time, although it starts typically in the beginning more so than after some time. And many children, there are studies on pre-morbid, how do the faces, how children look, pre-morbid, any signs of having problems later on, and the backward continuation studies where people have followed up, say, from childhood pictures of adults with psychosis. They have found that there were some precursors of the psychosis prior to onset of florid positive psychotic symptoms. Now, what are the diagnostic dilemmas when you diagnose psychosis? So for a neurotypical child, a child might have overactive imagination and vivid fantasies. And that's not psychosis. There is a lot of talk about early intervention in psychosis and high-risk states. And if there is, say, paranoid thoughts, there is attenuated or, transient psychotic symptoms. If there is a strong family history and a recent deterioration in functioning. However, I remember this patient in Maudsley, Annie, as a liaison adolescent psychiatrist there as well. And I asked, do you smoke? And he said, not tobacco. So it's quite common for adolescents, particularly in the West, to actually smoke cannabis. And cannabis-induced psychosis is not schizophrenia, although it might lead on to have, more serious consequences. But this has to be differentiated from other psychosis. Sometimes juvenile onset obsessive compulsive disorders, say obsession of having something symmetrical or something bad will happen, might get confused with a paranoid delusion. In ADHD spectrum conditions, lack of reciprocity or idiosyncratic belief. However, ADHD usually does not have acute onset, although there might be acute change in behavior if there is a comorbid psychopathology developing, and it's a long-standing pattern. In mania, like florid delusions, elaborate thoughts, and rapid speech, as opposed to withdrawal, which happens in psychosis. And last, we come to schizophrenia, which is rarer in children, of course, much rarer. There could be an acute onset or a slowly developing one, and there is almost always a change in functioning. Now, I think in the entire talk, if you want to take one slide, which is of clinical relevance in day-to-day assessments, I would talk about this, because these are the differential diagnoses as a job-in clinician we have to keep in mind when we see a child with psychosis. Now, when we talk about at-risk mental state, this is a recent systematic review published in the American Journal of Child and Adolescent Psychiatry. What is interesting is that when people diagnosed at-risk mental state, only 1 in 6 of these youngsters developed psychosis later on. So I think, you need to, the authors caution about the use of at-risk mental state, and they in fact attribute some of it as a sampling and recruitment strategies. That's why they got picked up. So, psychosis or schizophrenia does have a stigma. Now, this we are talking about before the onset of psychosis. So once there is clear psychotic symptoms, of course, you need treatment. And the duration of untreated psychosis, DUP, if that's shorter, there is better outcome. But this slide is, this group is about people who have not yet developed psychosis, and we are talking about at-risk mental state. Now, psychosis in children and adolescents, sometimes children can have hallucinations normally. That is not part of a psychiatric disorders. There could be acute and transient psychotic disorder, a brief reactive psychotic sort of symptoms, like in like a Scandinavian concept, where there is a trauma and there are some psychotic symptoms, along with probably mood symptoms and other symptoms of trauma. Prodromal symptoms of anxiety and depression. Childhood onset schizophrenia is very, very rare. So much so, I remember when I started doing this review back in 2006, people said, you are doing research on a topic which, does not exist. And quite rightly so, children with schizophrenia, which is childhood onset, means below 12 years of age, the prevalence is 1 in 10,000. So you might be a child mental health professional and not see a child with childhood onset schizophrenia in your entire career. However, things drastically change once you are talking about adolescents. 1/5 of all adults with schizophrenia have onsets in adolescence. And of course, I have talked about the misdiagnosis of psychosis and other things. And it could be adolescent onset psychosis, also could be the first episode of a psychotic bipolar disorder. Now, I have covered some of this. The pathognomonic features are very similar. There is a prodrome, acute onset, recovery phase, and the residual phase. Almost always, like all symptoms, all disorders, which happens in adults and also happens in children and adolescents, if the age of onset is earlier, maybe because of genetic anticipation or any other genetic factors, usually the genetic loading is more, and they cause more impairment and often has poorer outcome. So, there is moderate to severe impairment. The way to go about is, assessing the child well. You don't have to come to a diagnosis in the first interview you have had with the child. You may need to see the child for more than one occasion. And all children with suspected schizophrenia should be evaluated for clinical conditions that may be associated with it, developmental disorders, substance misuse, PTSD, stressors, medical conditions. And please examine, for all the doctors in the audience, a child with suspected schizophrenia, do a physical examination. I think it's important to do a physical examination for all psychiatric patients that we evaluate. And you particularly would actually be more mindful about the finding organic cause or do more investigations if there is focal neurological signs like reflex, brisk reflex or upgoing plantar, or if there's a history of seizure and an acute onset of psychotic symptoms, or there is a past history of a medical illness that can present with psychiatric symptoms, say, porphyria, or if there is a family history of a medical illness that can present with psychiatric symptoms, say Wilson's disease. So these are points where you need to be more cautious about investigating a child for a medical cause which is causing the psychotic symptoms. Now, coming to the American Academy guidelines for treating children and adolescents with schizophrenia, the practice parameters, this was published in 2013. And the recommendation 4 clearly mentions that antipsychotic medications is a primary treatment for schizophrenia spectrum disorders in children and adolescents. And that's the mainstay of treatment. However, that doesn't mean that you don't go ahead and complement that with psychosocial treatment and psychological treatment. We are dealing with a child here. So it's crucial that we practice the principles of child and adolescent mental health with any child we see. Of course, I would encourage you to read the NICE guidelines, which talks about how to treat children with psychosis. And going to the olden days when we first did the review, which we published in Schizophrenia Bulletin and also as a Cochrane review in London on childhood onset psychosis and schizophrenia, we did not find actually a lot of trials. There were only 6 trials. And when we compared typical with atypical antipsychotics, we found that the meta-analysis did not show a significant difference between the two. Now, of course, this is intriguing, but it's not easy to do trials on this group of children. Imagine, having consent from parents, doing a trial, somebody getting a comparator treatment, somebody getting your intervention arm. This is a difficult trial to do. Now, when it comes to adolescents, the second systematic review which we published, we focused on atypical antipsychotics for psychosis in adolescents because that's what we all treated. Again, we found that the difference between typical and atypical antipsychotics were not supported by evidence. Now, there is a study called the very famous study called TIOS study, where there were similar findings like olanzapine, risperidone. The degree of symptom reduction was not statistically significantly different between the groups. However, the follow-up was only 12% for the adolescents who participated in the study. And, we can't conclude about long-term effects of these medicines from this study. Now, when we published this in Schizophrenia Bulletin, we had again shown that the findings, these are based on already conducted randomized controlled trials. However, if evidence is so limited, it's a good idea to see what child psychiatrists actually do. So we did a survey, UK-wide survey on antipsychotic medication, and we asked child psychiatrists. At that time, I used to work with consultants in a Gardner unit in Manchester, and we asked, what is the drug of choice which you would prescribe if there is an adolescent with psychosis? How would you go by? And if you look at the pragmatic steps that you could use is, first of all, is make sure that you have got the correct diagnosis. There is no test that can confirm the diagnosis other than a good history and a good mental state examination. Start the young person on atypical antipsychotic medication. That was the preference for most consultants UK-wide when we did the survey, and is preferred option for most consultants and child psychiatrists all over the world today. Talking about effect size, I think for somebody with psychosis where you want quick response, the order of drugs like risperidone, olanzapine, quetiapine, aripiprazole, in that order, often it's used. Risperidone being more efficacious, of course, has more side effects sometimes. And for occasionally, clozapine could be tried for treatment-resistant patients. Depot antipsychotics, seldom used. There is no evidence-based for adolescents with psychosis with poor adherence to treatment. ECT, I haven't used ECT for adolescents with psychosis in Maudsley when I was a consultant at that place. So it is seldom used. However, the American Academy of Child and Adolescent Psychiatry mentions that it may have a role on very selected patients. Of course, in mood disorders, it might be treatment-resistant mood disorders might be a bit more used rather than in psychosis. But, there is a mention about that. It's seldom used again. Now, what is the lived experience of adolescents with antipsychotics? It is complex to take antipsychotics for adolescents. So this is a study from Canada, and the adolescent said that if I have a problem, I'd rather beat it myself than take refuge of somebody or something. So letting something else take care of it. So there is a sort of perception that if you take medicine, you are giving your control to someone. There is, of course, pressure to conform to the youth culture. I went off pills by choice. So this is an adolescent who is developing strong sense of autonomy. And, functioning is often impaired because this is an adolescent who said that they don't make me feel like myself. So they don't make you feel like yourself. So the relationships, and this I feel is very poignant. The quote is, I have different friends now. The stigma of psychosis, often we would see adolescents with psychosis hanging out with others with similar life experiences. There are some very good Instagram groups about young people. Not all of them are adolescents. Some of them are young adults about their experiences. And in today's world, I think it's good to know that people are coming out about their experience. However, in 2022 going on to 23, the patient's experiences of the treatment is something we need to consider as child psychiatrists. How do you prevent side effects of antipsychotics? This is a paper we published in Minerva Psychiatrica, and I'll tell you how we approached it. Was we thought that if we take side effect by side effect, say cardiac side effects. So having a history of a pre-existing structural cardiac problem, say somebody having Down syndrome, which is known to have septal defects. So you would be more cautious because there might be conduction problems. So there are some primary prevention strategies and secondary prevention strategies. Now, of course, somebody who is psychotic and very restless, it's not easy to get the ECG done on day one. But hey, get it done on the second day or the third day and document the QT interval. I think, that's the safer practice. So I think, if you take symptom by symptom, that's how you would be more cautious and a safer doctor. You need to understand that, say, in depression, often the dose of an antidepressant would be the same dose on which the adolescent has achieved remission, which you continue for the time period that you want to give the medication to the child. However, in psychosis, often the maintenance dose could be less than what was required in the acute phase. And you need to worry. I think, this is a bit of a stereotyping, but sexual dysfunction in adolescent boys and weight gain in adolescent girls are often, these are the key indicators for poor adherence. And, unless you ask these to the children, you would get somebody stopping the medicines repeatedly, having a psychotic relapse and coming back to you. It's a frustrating experience for the child. It might be traumatic because the child needs to be, say, restrained and given injections. And it is frustrating for the clinicians as well. So I think the key to getting good adherence is asking about their experience and asking about side effects proactively. There is a paper from Canada about clozapine use in children, again, a retrospective review. And you would see that, for adolescents, patients took 33 days to get to the optimum dose of clozapine. Almost always these were inpatients, so 60 days the patients had mean length of stay in a hospital in an inpatient unit when clozapine was started. The authors do report about high risk of metabolic side effects. So clozapine is an option for treatment-resistant patients, but you need to be cautious when you do that. And I think if you have the facilities, admitting such a child is always a better option. Now, where does psychological interventions fit into all this? So we did a published Cochrane review at the peak of pandemic, first wave actually, and part of it in the Schizophrenia Bulletin in 2020. And we found that, various kinds of psychological interventions, there are trials. So psychoeducation, cognitive remediation therapy, cognitive remediation using computers, group therapy, these are adolescents who might have difficulties into mixing with peers. So group therapy, it makes an intuitive sense. Families, are very stressed with an adolescent with psychosis. So family therapy. And I have to make a caveat here. For all the studies we identified in our review, all patients were also on medication. So the details were not, unfortunately, mentioned by the authors, but they were also on medications while they had additionally given a comparator arm and the intervention arm, given one mode of psychological intervention, and which was compared either with treatment as usual or a second type of psychological interventions. And we found that, there were 2 studies on cognitive remediation in adolescents, which was, compared with treatment as usual, with outcome changes in one parameter, like short-term memory, which again, the certainty of evidence is not very high, it's low, but the overall mental state did not change, the global state did not change. Coming to group therapy, the global state did change, in these settings. However, there was no differences in the mental state. But, these children, the mental state, because both the groups are getting medications, so the positive psychotic symptoms have reduced in both the groups. Cognitive remediations with psychoeducation, very intensive sort of treatment with only psychoeducation. This trial did not show any difference. Similarly, there are other trials with multiple psychological interventions in one arm versus another type of psychological intervention, non-structured group therapy versus family therapy. In this trial, it did not show. Now, the effect that because these were two well-done psychological interventions, they were done for both groups. One thing you have to remember that because one was not superior to another doesn't mean that they were useless. So I think we are talking about children here, and we have to embed our treatment in the milieu and the context of a family and the school and education, because stigma reduction, and if the adolescent is able to go back to school, have a career, complete education, even if that's the vocational education, he or she has a life. So it's very important that the psychosocial aspect of it is looked into. As child psychiatrists, I would always talk about that. We were very pleased that this was, quoted in the Wikipedia page of Psychosis. And I would like to conclude that, medications do remain important and crucial in the treatment of children and adolescents with psychosis. There is almost no evidence in showing one medicine superior to other. However, practice follows starting on low-dose antipsychotic medications and titrating that slowly. Psychological care includes educational support, supportive psychotherapy, and a psychotherapeutic formal psychotherapy to intervention if that is available. So thank you. And any questions we would be happy to take together, myself and Esha, and we would also invite the two chairs, both of whom are very experienced child psychiatrists. So we would answer any questions all of you might have.
Thank you, Datta, for a very comprehensive presentation, including the research aspects that have been published in the Cochrane reviews, and also several practical points for the practicing psychiatrists as well as the trainees. Now I request the participants to type the questions in the chat box. There are a few questions already, so we'll start with use of this question is for Dr. Isha. Ma'am, do educate us about the use of melatonin in children for sleep issues. So this question is by Dr. Neelam Rati to Dr. Isha.
Thank you for the question, sir. Yes, melatonin is something that can at times be quite helpful for sleep issues. I think clinically what we observe is that it is important to be a little mindful of the nature of the sleep disturbance and the kind of disorder it is presenting in. So melatonin, as we know, is it is a medicine that is beneficial for sleep, but also it turns to work, along with resetting the circadian rhythm, with helping the regulation of sleep establish better. So especially when we're dealing with children who have developmental disorders, who have regulation difficulties and other aspects of their functioning as well, we find that melatonin can sometimes be very helpful. And in fact, just to add, sometimes we do find that using benzodiazepines, which sometimes work so well for adults, actually don't help children equally well. And some children may even have paradoxical activation with using benzodiazepines, for sleep-related difficulties. So yes, melatonin does help, and especially where you're noticing that there is a developmental disorder in the background, there are regulation difficulties. Those might be children who might specifically benefit from this molecule. And similarly, starting low, going slow is the golden rule to be followed across all.
Yeah, thank you, Dr. Isha. The next question is by Hev Paris. The question is that what advice can you give on knowing the difference between autism, burnout, and psychosis? So
I think this question is probably for Soumitra.
Yeah, Dr. Soumitra, yeah.
Yeah, meaning I think psychosis is a different illness and disorder than autism. Now, there isn't, so there are some studies which have done long-term follow-up of autism and ADHD. So yes, there is more chance of comorbidity in neurodevelopmental disorders to develop psychosis, depression, but one doesn't lead to another. So I think, I would differentiate these two. Clinically, psychosis usually have a day of onset, whereas autism would have, precursor, and, it would be a lifelong. You and I couldn't develop autism suddenly. So it's the history. If you take a good history, you would find that from very early on, before 3 years age, before 2 years age, there may have been some differences with the parent notice with if they have another child. So I would differentiate both as very different illnesses. Somebody with autism may develop comorbid psychosis. We would treat that separately. Any other opinions from the panel?
Yeah, so these both conditions, if you look at the historical aspects of autism, initially when Kanner proposed, when he observed a group of about 11 children, and he used the term autism to define these children. Though the first use of this term was by Bloiler in adults with schizophrenia. During the times when Kanner had described autism, there were people who felt that he was just talking about childhood onset psychosis, and they in fact felt that there is no separate condition, and Kanner is probably talking about the same condition as childhood onset psychosis. And if you look at some of the earlier classificator systems, even till DSM 3, the disorders were classified mostly under the psychosis in the onset in the early childhood. Then subsequently, the term pervasive developmental disorders was coined in the DSM-3R and DSM-4. And we all know that in DSM-5 and ICD-11, it has been changed. The terminology has been again changed to autism spectrum disorder. Psychosis, as Dr. Soumitra mentioned, it's a completely different condition. It's a severe mental illness. Most often, the onset is in adolescence. So, yeah.
Thank you. Yeah.
So there is a question in the question and answer section of the chat box. The question is pertaining to pharmacological management of behavioral addictions. So I request Dr. Isha to answer the question.
Yeah, one often wishes there was a magic drug for behavioral addiction for children and adolescents. Just like we talk about treating aggression, treating some target symptoms in autism. Similarly, addiction is one of the things, that if you read a lot of, the literature about different kinds of addictive disorders, not just behavioral addictions, but all kinds of addictions, they all seem to actually be epiphenomena of underlying vulnerabilities. Whether there are temperamental vulnerabilities, whether a child has ADHD, whether, sometimes even family-related difficulties, where these so-called addictive behaviors are used as coping mechanisms. So a lot of, the excessive technology use or, media use or whatever behavioral addiction the child has, a lot of that seems to be stemming in from a vulnerability that, is actually more pervasive. It's not just about the addiction behavior per se, but a more general, children with social skill deficits, children with emotion regulation difficulties, with coping skill related problems. So the So addiction, especially in children, is clearly one area where unless, again, there are very well-defined targets. So if there is aggression, if there is depression, if there is suicidality, if there is a lot of anxiety, so unless you have a clear symptom that can actually benefit from the use of a psychopharmacological molecule, there is no standard drug for behavioral addictions per se. You're better off treating the different underlying vulnerabilities that you should identify with a good clinical assessment of the child. But having said that, sometimes for different kinds of addictive problems, including behavioral addiction, when we liaise with our addiction medicine colleagues, using medication like baclofen or naltrexone, they have been tried as adjuncts to the primary focus being on psychosocial interventions. So, much like what molecules are used for the drugs.
Thank you, Isha. So we have another question by Bornali. Is there any way to distinguish psychosis that is induced by trauma versus the disorientation from dissociation due to trauma? I would request Dr. Soumitra to answer the question.
See, you will have a history for the trauma. In psychosis, which happens de novo, you will not have the history of trauma. However, you may have to if traumatic dissociation, the way brain processes the trauma event, is often fragmented. So, say as an adolescent who has been raped, and you asked about the events, they might not be able to construct what was happening, because our brain processes trauma that way. So I think if it's in the acute phase, I would first consider the trauma aspect. If there is a history of trauma, first treat it as a trauma-induced state, be it dissociation, low mood, whatever, and consider psychosis later on. Now, sometimes, we have seen that, after a traumatic event, there is florid psychotic symptoms for a short time. It could be a acute and transient psychotic symptoms rather than onset of schizophrenia. With good family support, good psychological interventions, so, some things like EMDR, etc., it might be better. Now, see, I work in a cancer hospital, so often children in grief, so adults who have had who are terminally ill and have young children, they may be traumatized. And one of the pathophysiological signs are that in trauma in children, there is puddle jumping. So the child may be absolutely fine, and after a few days, when the child has an exam, the child again gets very worked up and starts missing, whoever he or she has lost. And then once the stressor is done, again, more or less the child is able to function. Now, this sort of waves phenomena usually happens more in trauma rather than onset of psychosis, because, you won't have this amount of variability. So I would go by the clinical picture and get history from multiple sources and be patient. I think that's how my approach would be in a child who is traumatized.
Yeah, thank you, Dr. Soumitra. As I see that there are no further questions in the chat box, I hand over to my chairperson, Dr. Kshitij.
Yes, thanks for both these talks. Very engaging, very informative, both Isha's talk and Soumitra's talks. We had a good audience asking some good questions as well, so made for interesting discussion. If there are no more queries, I just wanted to add to a couple of things that were being discussed. So of this question that Soumitra was answering about trauma-induced psychosis and trauma-induced dissociation, I've seen in some cases, the trauma is a risk factor, but the initial reaction may be dissociative and subsequently diagnosis can change also. So we shouldn't be fixed that if someone has a dissociative disorder, it will stay like that. Diagnosis change because that stress may have been a very significant stress, and that would, because of some other vulnerability, it may increase the risk of psychosis subsequently. So we have to be careful in following up these patients. Regarding the behavioral addiction, I think Isha you made very relevant points. I mean, part of the problem is that we invent these diagnostic categories. There was no reason to have a behavior addiction, because then automatically one starts looking for a treatment for behavior addiction. Or actually, it is not a homogeneous diagnosis. There's so many other things. It's like ADHD, anxiety, depressive disorders, social skills, deprivation, so many things that predispose to these addictive behaviors, that unless you understand them, you cannot treat it. So just finding a treatment for behavior addiction makes no sense. But because these labels, we are bound to look at treatments for thinking that it's a homogeneous category. So yeah, good, interesting discussions. I don't have much to add. It was a pleasure listening to both the talks. Unless there's anything else, I'll hand it over back to Shomitro to make any future announcements which he may think of relevance.
No, good evening to all of you. Have a great night. We will come up with our next talk in January, which will probably be on autistic spectrum conditions, and then there would be another short session, maybe one of those next months on infant psychiatry. So stay tuned. Follow ACAM on the LinkedIn page. I think that's the easiest way you would get informed of the events. There are lots of free ACAM events, ACAM UK events. So you go to their website, there are free videos as well. So I think, we hope that this will increase the sensitize future child mental health professionals. Thanks so much. And thanks to the panelists, thanks to Gordana, and thanks to ACAM, thanks to them.
Thank you.
Good night. Thank you.
Good night.
Thank you all very much.
Find out more about becoming an ACAM member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.